And welcome. Good afternoon, everybody, and welcome to the University of Washington and ADI What's the Latest series. Today we'll be talking about methamphetamine and psychosis. My name is Mark Duncan. I'm one of the regular provider trainers as part of the ADI OUD training and technical assistance team, and I'll be facilitating this webinar today. With the growing use of methamphetamine and methamphetamine-associated psychosis, is a problem that more and more of all providers who are working with this population are seeing. And we know that this problem can impact the ability of patients to engage with treatment providers and recommended treatments for medical, psychiatric, and addiction issues. And this talk, we're going to, and so this is coming up, and we get a lot of requests around help with dealing with this issue. And so this talk will describe what methamphetamine-associated psychosis is and how it differs or does not differ from underlying psychotic disorders. We'll talk about some approaches to addressing these symptoms. And we're fortunate enough to have our speaker, Dr. Jonathan Buchholz, who I'll introduce in a minute. So let's go to the next slide. A couple of Zoom housekeeping. This call is being recorded. And when you're not speaking, please keep yourself on mute. You can find those audio and video controls in the lower left corner of most desktop screens. If you have questions along the way and you want to type those into the chat box, doing that is a great option. And I'll try to facilitate getting most of those questions into the during the talk, and then potentially, and then at the end when we have some time for discussion. And if you want to go ahead and just kind of sign into the chat with your name and organization and maybe your role, that's always nice to kind of get to know people. Let's go to the next slide. So I'd like to start off and begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. All right, next slide. Okay, so our speaker today is Dr. Jonathan Buchholz. He has earned his medical degree at the University of Washington and then continued at the University of Washington to complete his general psychiatry residency and addiction psychiatry fellowship. He is the medical director of inpatient psychiatry at the VA Puget Sound and director of the addiction psychiatry fellowship at the University of Washington. He spends most of his clinical time on the inpatient psychiatry and addiction consultation services at the VA, caring for patients with co-occurring disorders. Dr. Buchholz is an assistant professor at the University of Washington with academic interests centered around improvement of education for substance use disorders to medical students, psychiatry residents, and addiction fellows. Dr. Buchholz has earned several teaching awards from the medical school, the general psychiatry residency, and the psychiatry and behavioral sciences department at the University of Washington. We are very grateful to have Jonathan join us today, talk about his expertise in this area, what he sees clinically, and just help us provide some insights into this issue that we're all seeing. So Jonathan, thank you very much for joining us today and for presenting on this topic, and I will turn things over to you now.
Great. Thank you so much, Mark. Really appreciate that introduction. And I appreciate everybody's interest in this topic. We have come a long way since the 1990s. I actually grew up in a small town, Sumner, Washington, where in the mid-1990s, the clandestine production of methamphetamine in small batches in people's trailers and apartments and homes was one of the worst in the country. Many of you who work with patients who use substances deal with this patient population where differentiating psychosis and psychotic symptoms from substance-induced or underlying psychotic disorders becomes really challenging. I will present information today, some review, hopefully some new things. And I always, when I talk about this issue, wish that when I give the next presentation, it's going to have an associated great answer or magic bullet. And those of you who do this work understand that we're not there. And so as we go along, as Mark said, I am very interested in questions and am open to interruptions in terms of feedback and questions. So today we're gonna really unpack the differentiation between substance-induced psychosis, primary psychotic illnesses, why it actually matters, sometimes more important than others, and how to go about making these diagnoses as it informs the care of the patient that you have in front of you. We're going to name kind of two types of associated psychosis associated with amphetamine use, and how you differentiate those things diagnostically. Very simply, the acute intoxication, which lasts days or weeks, and the more intractable chronic psychotic symptoms that we may see associated with amphetamine use. And then we'll go over some treatment modalities associated with improvement in substance use induced psychosis, treatment of the actual substance itself, and then the underlying psychotic disorders that are associated. So as a landscape, many of you know this, and this is, there's folks from all over the state here. This is just King County data that I pulled today, looking at the scope of the problem when it comes to poisoning deaths, which isn't psychosis per se, but it is a reflection of how prevalent some of these substances really are in our state. As you can see here in the upper right corner, the poisoning deaths have gone up really, really dramatically since 2020 and COVID, primarily being driven by the combination of opioid and stimulant overdoses. But what you'll see here in the bottom slide on the right side is, aside from fentanyl, actually methamphetamine is associated with a lot of overdose deaths. That is reflective of how available amphetamines are in the state of Washington, drug supplies from Mexico primarily coming up the I-5 corridor being fentanyl and methamphetamine. And then what is, I think, really also quite relevant to this patient population, and as a lot of you experience, that patients who are attempting to use methamphetamine, cocaine, often are getting substances that are adulterated with fentanyl, and just the opposite, that folks who are attempting to use heroin or opioids of some sort may actually get substances that have methamphetamine in them as well. So the two 900-pound gorillas here are fentanyl and methamphetamine. Fentanyl, though we are, it is killing so many people. We have medications that treat that when we get patients on those quite readily. And methamphetamine is a little bit different animal, and unfortunately harder to treat when it comes to medication management and psychotherapeutic interventions. So starting with DSM criteria, just the very basics, how do we actually differentiate substance-induced psychosis from primary psychotic disorders? And what the DSM will tell us is that if a patient has been using a substance within the last month, you can't really make a full diagnostic, a diagnosis of an underlying psychotic disorder. A substance-induced psychotic syndrome would not be accounted for by a pre-existing mental disorder. It would not be due to delirium, and this is important in cases of acute intoxication on amphetamines or another substance, as patients sometimes can be delirious and not necessarily psychotic, which should be something that resolves fairly rapidly in the inpatient hospital setting when the delirium is actually treated, either because of the substance itself or because of some other medical issue that's going on. Furthermore, these symptoms after a patient stops using should not really last beyond a month in most situations. The exception to this rule has become amphetamines, and we'll talk a little bit about the phenomenology of that, and what the theoretical model is on why we're seeing that occur. Though there's no definitive answer to that, there are some theories about why psychosis with amphetamines might just be a little bit different animal that persists even beyond the days or weeks that you might assume someone who's actively using amphetamines may have symptoms of psychosis. So the other thing that I always really emphasize, so I work primarily in the acute care setting, and 75% of our patients on the acute inpatient unit have co-occurring substance use disorders. And it can be terribly difficult to differentiate in a spot or in a moment in time what is driving psychotic symptoms or even other mental health symptoms. But from a longitudinal standpoint, I think what I find most helpful is actually history. And this can be really challenging for a patient who's got disorganization, paranoia, active psychotic symptoms. But our sort of medical training and training in mental health has really focused on the notion of asking a patient why they're coming in for treatment right now, and starting with a really what is your current problem, and then working backward in terms of gaining history. And what I would actually encourage people to do when they have time with these patients is to get a longitudinal history. Actually start with, where did you grow up? Who was in your family? What were the developmental issues going on? How did you do in school? What kinds of relationships were you having? When did things change? And sometimes you can get that from the patient, sometimes you cannot, and actually having informants or family members give that history can be very useful. And in particular with folks who have periods of abstinence or sobriety or recovery that do not involve the substance, what kind of functioning was going on at that point? And the story of schizophrenia, the story of bipolar disorder will diverge from the story of substances at times. Of course, it can be very challenging when somebody is using amphetamines or using a stimulant in and around the time that you would typically associate with development of schizophrenia, for instance. Patients who are 19 to 25, who are having that prodromal syndrome associated with the development of schizophrenia. If they're using stimulants frequently during that time, it can be really challenging. However, if you have a patient who's doing well, who's had really no mental health symptoms whatsoever, who acutely starts experiencing psychotic symptoms that transiently come and go during periods of intoxication, but then start to persist with really concurrent and ongoing amphetamine use, can give you a little bit more picture of somebody with a substance-induced psychosis. The other thing that's really useful is actually thinking about some of the particular symptoms that you see in substance-induced psychosis that actually may not be associated with schizophrenia, and just the opposite. So what this chart does is it actually shows some overlapping symptoms that we often sort of focus on: hallucinations, psychomotor agitation, disorganization of thought. Those things can be very overlapping in the two other very common diagnoses that are associated with psychosis, and that is schizophrenia and bipolar disorder type 1 mania with psychotic features. And again, we focus on these positive symptoms, but actually when you go to the negative symptoms of schizophrenia, what you'll see is that's a very helpful way to differentiate with some of these patients. Substance-induced psychosis, though sometimes can have difficulty with psychomotor retardation and flat affect, as we'll talk a little bit about in the next few slides, it's not nearly as prominent as you would see with somebody who has schizophrenia. The other thing is the compulsive nature of these positive symptoms tends to be a little bit less. Now, that's not to say that that can't occur, but it is possible. So this is I think, useful way of really differentiating schizophrenia from substance-induced psychosis in terms of those more prominent negative symptoms occurring in schizophrenia. Depression, people can have symptoms of depression, but that real sort of psychomotor retardation, flat affect, poverty of connection and speech, those are more consistent with somebody who has schizophrenia. Bipolar disorder is a little bit more challenging because these episodes are transient, then can come and go, and amphetamine use can actually spark a manic episode. And when patients are hospitalized, often they're not, they're treated and their substance, or their psychotic symptoms resolve. And then the question becomes, is this methamphetamine actually induced mania, or is this an underlying bipolar disorder? And again, the history can be really helpful in differentiating that. So the most common associated psychosis is actually with cocaine, and it tends to be transient. Methamphetamine is a little bit more prominent when it comes to long-term psychosis. The other thing here with cannabis is just a quick note is, these numbers could actually be antiquated. This is from a study in 2018. And the more potent cannabis that we see over time, the more likely patients are to have transient psychotic symptoms. Again, not necessarily something that persists, but methamphetamine remains this other agent that really can be problematic long-term. Just the scope of amphetamine use, so 1.6 million adults using in the United States. And if you take that sort of 17 to 30% number, you're really looking at a pretty big population of people who are experiencing associated psychosis with use of methamphetamine in the hundreds of thousands. So I talked a little bit about, these differences between transient psychosis and persistent psychosis. So there was a cross-sectional study done that showed more than half of the patients with methamphetamine psychosis actually saw a remission of their psychotic symptoms within a week of abstinence from methamphetamines. I think a lot of times we think of these patients who have the persistent psychosis and it becomes very challenging. But the rule is more that these are transient symptoms, that they don't persist beyond the time that someone is actively using amphetamines, at least in and around the time, a week here or there. But there's this other category, and this is the one that I think a lot of you are really interested in and are flummoxed by, is the psychotic symptoms that remain in 20% or 26% of patients after a month, and even 16% after 3 months. So the question really is, what is going on? Is this a genetically vulnerable population that methamphetamine actually triggers a development of psychosis or unlocks underlying schizophrenia or psychotic disorder, or is something else going on? We don't necessarily know the answer to this, but I do want to go over very quickly the pharmacology behind methamphetamine and cocaine. All right, so everybody see the mouse party? Somebody give me. Yes, wonderful. So this is a cool website. This was developed at the University of Utah in partnership with SAMHSA, and it's actually really great educational material for patients, but it goes over some of the differences in terms of what's going on pharmacologically. So difference between their version of the rat using cocaine, who's paranoid here in the back, and methamphetamine has to do with how irritable and skinny the rat is. I'll leave that to you to judge. We're going to start with cocaine.
Dopamine transporters are responsible for removing dopamine molecules from the synaptic cleft after they have done their job. Cocaine blocks these transporters, leaving dopamine trapped in the synaptic cleft. As a result, dopamine binds again and again to the receptors, overstimulating the cell. Like other drugs, cocaine concentrates in the reward pathway. However, it is also active in the part of the brain controlling voluntary movements. This is why cocaine abusers are fidgety and unable to be still.
That is cocaine. Here is methamphetamine.
Dopamine transporters are responsible for removing dopamine from the synaptic cleft. Because meth mimics dopamine, it is taken into the cell by the dopamine transporters. Once inside the cell, meth enters the dopamine vesicles, forcing the dopamine molecules out. The excess dopamine in the cell causes the transporters to start working in reverse, actively pumping dopamine out of the cell and into the synapse. The excess dopamine becomes trapped in the synaptic cleft. As a result, it binds again and again to the receptors, overstimulating the cell. Meth is highly addictive because it works directly on the brain's reward pathway, making the user feel intense pleasure and exhilaration.
All right, so as you can see, the difference really comes down to how potent and or the levels of dopamine that we're talking about. Whereas cocaine blocks that reuptake, amphetamines actually also produce a dopamine flood from the inner synaptic areas. So this is a study actually that's been replicated a number of times, looking at dopamine levels of rats in the nucleus accumbens. So they put a probe in there and they will actually measure what kinds of basal levels of dopamine occur and then add external stimulation, either food, sex, water, or substances. And what you can see is based on basal levels of dopamine in the nucleus accumbens, cocaine is about 3.5 times as potent. And amphetamines actually are about 10 times as potent as what a rat might experience on a day-to-day basis with food or sex or something like that. So these are incredibly potent substances, amphetamines being potentially 10 times more potent than having an orgasm. And I say that to my trainees often because people ask this question, like, why would you ever use amphetamines if it makes your teeth fall out and you become psychotic? Because it's incredibly rewarding. So neurotoxicity associated with methamphetamine. So what does this do to the brain? So not only because of the dopamine rush, which theoretically can actually increase psychotic symptoms, that increase in dopamine and the dopamine hypothesis behind psychosis, but it also can result in neurotoxicity. This actually leads to dopamine nerve terminals dying off. And this is focused, and this is a sort of famous study by Nora Volkov in 2001, taking a look at dopaminergic functioning when a person is using amphetamines. And what you can see here is that where through a cross section, taking a look at the nucleus accumbens, you'll see significant activity in the dopaminergic areas, whereas a methamphetamine user actually has significant damage here. So how does that actually translate to functioning? And what you'll see, actually, they did this motor task, which is the more amphetamines that you used, those who were using substances and had a reduction in dopamine transporters, took longer to do these motor tasks, and also had a more difficult time with memory tasks with the use of amphetamines. This actually also, unfortunately, takes a long time to recover. So if a patient has been using amphetamines for long periods of time, you'll see here the normal control, and this is a cross-section through the nucleus accumbens area again. This is lower down in the brain in the cerebellar region, but you'll see a lot of that dopamine destruction here, and it really in this study sort of on average was taking 14 months or at least a year to recover. And that's really, I think, clinically relevant for the patients that we take care of who are acutely stopping their amphetamine use, because they have a very difficult time with some of these protracted depressive symptoms, protracted psychosis, protracted anxiety and lethargy and difficulty thinking that can take a long time to recover, and why actually getting time away from amphetamines is so vital and so difficult. So let's go over a case. It's a 24-year-old guy. It's a patient who I took care of, who presented to the emergency room in distress, said that his roommates were poisoning him through his heating ducts. He's been using amphetamines for binge fashion for about 3 years. He uses while he's partying, says he last used 2 days ago, but passed out for the last day prior to coming into the hospital because they are pumping toxic gas into my room. So when thinking through this, you want to think about the things that you want to know about him. What are the kinds of workups that you want to do? I'm not going to spend a ton of time on the acute part of this because I know a lot of you do more outpatient care, but his heart rate was elevated, his blood pressure was elevated, his Kim panel was normal aside from an elevated creatinine, a lower functioning of his kidneys. CBC was normal aside from a slightly high white count. His UTOX was negative aside from methamphetamine. As you consider follow-up labs, patient becomes increasingly agitated that he's being poisoned, and what's the next step in management of this patient? So you can give him Haldol, you could give him Ativan, you could give him olanzapine, you could use restraints. In this situation, I give Ativan, and the reason for that is that some patients who are using amphetamines, particularly in a binge fashion, might actually have higher rates of rhabdomyolysis or kidney damage associated with them being up for days and using amphetamines. And in those situations, actually giving antipsychotics acutely can worsen that and or cause QT prolongation. And patients who are dying from amphetamine-associated use are likely this is caused by cardiovascular collapse, having a massive heart attack, having a stroke, and actually giving an antipsychotic might be problematic in that situation. So benzodiazepines in supportive care are actually much more safe. And then once you get those labs back, if the patient does not actually have underlying renal disease, you can use antipsychotics. So he's found to have a CK of 2020 or 2,200, and he was admitted for workup and treatment of that. After some supportive care, his creatinine normalized, it was downtrending. He was remaining convinced that his roommates were poisoning him. So think about in your mind how you actually then start to try to differentiate the diagnoses. So we actually talked to the patient and his mom. He had 2 years of community college before dropping out abruptly at the age of 21. He used various substances recreationally until methamphetamines became routine. He worked as a server for a local pub until a year ago when he was fired for screaming at a customer. And he is increasingly paranoid over the last year, intermittently going back to his parents' house every so often to ask for money. Mom says that he lost significant amount of weight, has been increasingly aggressive toward his father at times, and then totally somnolent at others. Only recently did he start making comments about his roommates trying to kill him, and mostly these happened during episodes when he's also agitated. They had no history of severe mental illness. From a mental status standpoint, he had good eye contact. He was slightly intense. He was fully oriented, mostly linear in his answers. He was a little perseverative. He said that he heard his roommates plotting against him in the ER 2 days ago, but nothing since that time. And he acknowledged that using meth made his worries about his roommates worse, but he couldn't shake the feeling that it was still really happening. So what do people think? What kind of diagnosis might this be? Is this substance-induced psychosis? Is this primary psychotic disorder? Is it a potential of both? Would you be able to make this diagnosis right now?
And people should feel free to type a response into the chat, or if you just want to unmute for a minute and say your thoughts, that's fine.
So, for me, I used methamphetamines for 4 years straight, and the last year was really bad. Like, I thought people were digging holes under my house to come and pull me through them, to kill me. And I stopped using, and I finally got some help, and they diagnosed me with PTSD. So I guess considering what he's been through, I wouldn't know.
Hey, Ms. Hoskins, thank you. Ms. Hoskinson, thank you so much for that comment and lived experience. It's super helpful to hear your experience. And I would say that it's, in this situation, really impossible to actually differentiate. With that said, what do you actually do in this scenario? And the data is really unclear when it comes to, is there a particular medication or agent that is better than another? What we know is that antipsychotics do help with acute psychosis associated with amphetamines and can help in situations when people have more protracted symptoms. But when you look at the data as a whole, there's really no clear one antipsychotic agent that's better than another. There are studies that show some differences, but in the meta-analyses and overall sort of gestalt here, what we're really still doing is using the side effect profile to guide some of our treatment, and also recognizing that the second generation antipsychotics likely will have less of a potential for causing EPS. And I think this is actually fairly relevant for patients who are using amphetamines or cocaine consistently. And that's because these really potent dopaminergic agents really do have an impact on the dopaminergic system and put patients at risk for these movement disorders, and can be really challenging to differentiate. So the less chance of causing a movement disorder, the better. And so for those reasons, the recommendation is, from my perspective, is really second generation antipsychotics. And then how long do you give these medications? There's really, again, no complete answer to this. And generally speaking, the idea is use the medication to treat the acute symptoms, If the symptoms reduce or abate, you can absolutely consider tapering the medication off. And assigning these patients to long-term antipsychotics is also not a great idea, should this be a transient symptom that is related to substance-induced psychosis. What exactly do you give? So this is a recent recommendation put out by Dr. Harrington, and this was in Psychiatric Times, which I think is fairly reasonable. These slides will be available to you. Instead of going over these in sort of detail, I would just sort of point to this and say, you can use olanzapine, risperidone. Lower doses that are effective are always better. The higher you go on dosing of antipsychotics, the more likely there are side effects. And so the best treatment is the lowest that you can get away with that is actually helpful to the patient. And the idea is, if symptoms abate, you can consider starting to titrate the patient off of the medication over time. So let's continue the case. He presents to outpatient care for treatment of psychosis. Where do you actually start with this person? What do you do? And because the use of methamphetamine really increases the risk of transient and recurrent psychosis, the thing to really remember, and this is obvious, is that treatment of the meth or substance use disorder is the most important thing to do. So what works best for the treatment of amphetamine use disorder? And again, though I wish there was a magic bullet with medication, that is just not what we have found in terms of evidence. Behavioral treatments actually tend to be the optimal first-line treatment approach to reduce rates of psychosis in methamphetamine, because it reduces the idea of using methamphetamine more. What are the different types of treatment modalities that have evidence? Contingency management, cognitive behavioral therapy, 12-step facilitation, community reinforcement, and motivational enhancement. Now, again, there are some smaller studies that show some benefits, but this is the sort of larger global approach. This is a meta-analysis that used a network approach published in 2018, just taking a look at the different types of psychosocial treatment and what actually works better than other things. So these are actually focused on abstinence, which is only one measure. There are lots of different kinds of interventions and goals. But you can see here the blue is abstinence at 12 weeks, the green is abstinence at the end of treatment, and the lighter blue, abstinence at the time of longest follow-up. And you'll see here this community reinforcement approach and contingency management has the best data overall. With that said, some of these others certainly have reasonable interventions, particularly contingency management here, but this combination seems to be the most robust. And just to go over, community reinforcement really is a combination of patients and their families, along with the treatment providers that work with them. What are the medical treatments that have evidence for improvement of methamphetamine use? Again, there is no one medication that has consistent, definitive evidence that it significantly improves methamphetamine use disorder. The medicines that have some promise are methylphenidate, bupropion, modafinil, mirtazapine, and naltrexone. And I'll show you this particular, I pulled two studies out that are of particular relevance in my mind. One is, a lot of people have the question, do putting patients who have methamphetamine use disorder on stimulants help reduce their methamphetamine use? And the answer to that is sometimes. In this particular patient population, it becomes very challenging because are you going to put a patient on methylphenidate who has an underlying propensity for psychosis? Probably not. This study was not looking specifically at patients with psychosis. This was patients with amphetamine use disorder. And it did show some improvement in the patients that were taking methylphenidate over Abilify. Methylphenidate probably is the medication that has the most evidence for treatment of this population. With that said, those who have psychosis on top of that would probably be better off and less sort of risky to try other approaches. This is a study by Trivedi in 2021 that looked at the combination of naltrexone and bupropion for methamphetamine use disorder. And again, this is not a magic bullet, but you can see that over the course of the first 6 weeks and the course of the second 12 weeks, that there was some improvement in the number of methamphetamine urine samples that were positive when given naltrexone 380 milligrams every 3 weeks and bupropion at 450 milligrams. Now, I will say it's important to recognize bupropion at 450 milligrams is aggressive. People have had side effects with that. And again, not a magic bullet. So he follows up in outpatient care 2 weeks after inpatient treatment. He was started on risperidone. He was titrated to 2 milligrams before bed. He says, things are better with roommates. I don't think I need these medications anymore. He's interested in recovery and not using stimulants, but he's not interested in group therapy or any of that NAAA stuff. What would you recommend? What kinds of things have worked for people in the past? And this is where I'd like to really open it up a little bit more and get some of your all perspective and questions about treatment of these patients and your experiences. And I'm glad to answer questions as we move forward. The last slide here is sort of a real life situation in that he actually stopped his risperidone. He resumed using methamphetamine via inhalation, and he started having more psychotic symptoms. How do you engage these patients? What modalities have you used? What is the challenge here? What are the questions people have? What are the comments? I'd like to just open it up at this point and get people experience and comments and glad to answer questions.
Jonathan, there's a number of chats in about potential next steps, including things like peer support, other potential community involvements. I'm wondering, of course, contingency management. Anyone who's chimed in, either Josie or maybe, let's see, Lenita, you talked about some peer support and community involvement. Could you expand on that a little bit?
So yeah, here in Montana, I work with One Health and I run we have a drop-in center. I'm the lead peer here. And it's just people who can, relate, and we create groups. We do things like a soup and stories, a SUD support group, women's support group, men's support group. And that's literally what I do. I just support people that, because I'm a person in long-term recovery, and that's what we do.
I love that comment because one, I did not put peer support data, which absolutely has data. But the main thing is keeping people engaged and developing relationships. Because we don't have a magic bullet, it's really about keeping people alive and keeping them engaged in care until we can figure out how to help them. And peer support is so helpful, so wonderful for people who have lived experience, who can engage those at times who don't feel that the medical system is an ally to them. So that's wonderful. I really appreciate that comment.
I also had a thought about this patient specifically said that they weren't interested in group therapy or like 12-step or anything like that. Alternatively, getting involved in any kind of community where people are living the type of lifestyle that he's trying to get to, like people who also aren't using, and it can be any type of community, but it's just that kind of like social engagement and a way to really reinforce the habits of not using anymore would probably be beneficial, and not, like the culty group scene, which is really off-putting for a lot of people.
Great, appreciate those comments.
Anya, you had typed in contingency management, and Jonathan, you've mentioned that a few times. I know you both are at the VA, and so how? I mean, I'm assuming you offered this potentially to this person, or maybe they didn't. I don't know. Anya, could you talk about like how do you present contingency management to maybe a patient like this, and what kind of really resonates? And Jonathan, I'd like to have your comment too about that.
I'll defer to Anya if she's willing to comment.
Sure, I was trying to turn on my video. Oh, there we are. So it's a short-term intervention, and it's really easy to sell because it's really fun, and I used to think it was really juvenile, but since I've started doing it, it's actually just a really fun. It's a brief visit, and if they give a negative urine or whatever the target behavior is, and they get to get these little, it's like a raffle. They get to get little slips literally out of a punch bowl, and they might win prizes. And the prizes are little coupon books for the canteen. And it's just a nice, it's a very celebratory because they do usually win something, $3 or $20. And there's one in there, it's a jumbo, and it's $100. So, I mean, it's not something that's long-term, but it is something that can help people get through early recovery where they can, they can get rewarded and also get that brief, just fun experience with someone coming into the VA. And it's a difficult thing I think to set up because of the prizes, but I don't know if it's being done in the community or not.
I think there's a lot of work going on in implementation of contingency management. I think the idea is if you can, pair that reward very closely with the behavior you're looking for, it's quite effective, particularly in this patient population because of that sort of immediate engagement and ability to be very concrete in the positive reward. Also buying time for the brain to heal during these so protracted withdrawal phases. We have this fishbowl approach, as Anya described, which factors in a little bit of the sort of positive regard when somebody pulls out a really cool reward. It's very cool to see the group jump in joy for somebody who gets a big number.
Jonathan, could you comment? Maureen had wondered about, if a client voices he doesn't know what is real and feels others are out to get him, about some safety. I know I have talked with some providers that can be kind of unsettling, especially if some of the paranoia involves the clinic site itself, or maybe even some people at the clinic. So what's your thoughts on that?
Yeah, it's a really good question. And I think that this is an area that really is patient dependent, and it is very common, I think, for us to be concerned about safety, and not as common for people to actually be targeting us. But if they do, if there is a situation like this, I think it is really important to have an approach where there's providers available, where if there's potential for multiple people to be seeing the person, but also to, attempt to connect on the positive things, and really, I think, when patients have paranoia, when patients have delusions in particular, the likelihood of aggressively challenging those and changing their mind is not incredibly high. And so, cognitive behavioral approaches of, attempting to validate emotional distress without getting into the particulars of whether or not somebody in the clinic is a CIA agent. And that can be challenging at times. And if you can't get somebody off of that notion, and if there's no way to reality test in a way that's non-confrontational, it is challenging. And I think okay to have people go to different providers or use a more communal approach in these situations. But again, what I would say is that if that becomes an issue, safety is certainly a priority. And each clinic has to deal with that in the way that they know how best.
Thanks, Jonathan. Could you, there was another chat question here about, if someone is not necessarily recognizing the problems around meth use and but is having psychosis, how do you kind of talk about what that improvement, and we don't have a lot of time here, but how do you try to talk with someone about reducing or stopping their meth use to get some of those psychotic symptoms better?
Yeah. So again, this becomes very challenging when there is this, sort of confrontational, the meth causes these psychotic symptoms, right? And the patient saying, absolutely not, it actually helps me. What I try to do and what I find useful is to actually try to find a grain of alliance. And some people will say, well, it helps me. And I can say, what does it help you with? And if we can agree that when they stop using amphetamines, that they feel potentially blasé or it's difficult for them to think, I can validate that that's totally realistic and that makes sense when they're coming off of methamphetamine. And at the same time, then use motivational enhancement techniques to try to develop some discrepancy. Why is it that you're here then? What is it that you're really hoping for when it comes to engagement and treatment? There's a reason why you're here. And if it is that you're trying to get to the bottom of why your roommates are poisoning you and you still don't believe that it's amphetamines, is it possible that we can agree on, and this in this particular patient's case, he was in the same sort of agreement that he became more anxious and more distressed when he was high than when he was not, even though he was still convinced that his roommates were poisoning him. So the alliance was on the degree and the anxiety and agitation associated with the poisoning and not necessarily on the legitimacy of the poisoning itself. And that was an area that we could work through.
All right, thanks, Jonathan. Okay, we have 3 minutes left, maybe on 1 minute here, because then I have to spend a couple of minutes on upcoming trainings. If someone is having longstanding meth use and psychosis and antipsychotics are minimally effective, what are your thoughts about next steps in that sort of scenario?
Yeah, say that one more time.
Oh, the antipsychotics are not very helpful.
Yeah. So at times that is absolutely the case. I have seen that with patients. I also would then sort of go back, and this is one of the things that Lanita brought up is, making sure that we're doing a thorough psychiatric history. Maybe there's actually other factors going on. PTSD is so common for people who have substance use histories of trauma, be it formalized PTSD or not, underlying anxiety disorders and depression, even if you're not getting a huge amount of traction with that antipsychotic, is there other co-occurring mental health symptoms that you can use or treatment medications or therapy to try to help, and attempting to use other agents if there's psychosis, trying to help get somebody reducing their amphetamine use, and in some cases, really difficult and potentially intractable, where it's again about not necessarily getting rid of the symptoms, but trying to align and improve quality of life and engagement.
All right. All right. Well, with that, let's wrap up here. Thank you very much, Dr. Buchholz, for your presentation, and everyone's for their comments and questions. A couple of announcements on our upcoming trainings. So May 29th, we have an in-person training in Seattle. The question is we're going to be talking about, is this depression or opioid use, psychosis or meth? Really getting into some of these mental health symptoms. You know, for some people, they're able to stabilize on their buprenorphine or methadone, and over time, that can then start to give a chance for some of these mental health symptoms that may have been being kind of treated in some way with their opioid use to start to emerge. And so we're going to be getting into the nuts and bolts of that. What does that look like? How do you address it? How do you help people in those scenarios? Let's go to the next slide. On May 3rd in Spokane, we're going to be doing a whole person care one-day conference around skills to support people with OUD. This is going to be talking about everything from social determinants of health to shared decision-making around MOUD, touching a little bit on mental health symptoms, and really kind of looking at what are all the different areas that people might need some help as you help them recover from their opioid use disorder. Next slide. And then just the upcoming ADI training. So there's the Adolescent Learning Collaborative. You can see these dates there. The Nurse Care Manager Advanced Topics Series, Emerging Approaches for Fentanyl Use Disorder on the first Wednesday. An extended release injectable buprenorphine for OUD. This is a series that is starting next week that I'll be leading, getting into really how do you use medications like Sublocade or Brixadi to the fullest extent. This is going to be every other week from March 13th to the 24th. All of these are free, and if you have questions, email Allie Lennox there. All right, and then there's also other trainings, the monthly Care Navigator call, the monthly jail MOUD call, the quarterly emergency department call. If you are in any of these areas, these are all free. They really do a lot of crowdsourcing from providers from across the state. They're fantastic forums to learn more and share your expertise as well. All right, and there's some other resources online. And is that it? I think so. All right, I think that is it. So with that, we will wrap up. Thank you, everyone, for joining us today. I hope you have a great rest of your day and a good rest of your week. Bye-bye, everyone.